we are bringing experts and talking about the issues, primarily clinical and clinical management issues around management of COVID patients. I am going to start with recognizing the team who's running the show on Pakistan side at AKU in Karachi, and also two of my colleagues, and I'll just in a minute ask them to introduce themselves. Matt Levy and Asa Margolis are two emergency physicians who are working with me in the trenches and are not only in the emergency department, but also in the most difficult situation of pre-hospital and inter-hospital transfers. So why don't I start with requesting Matt, you first to introduce yourself, and then Asa.
Well, thank you, Junaid, and greetings, everyone. My name is Matt Levy. I'm a faculty member in the Department of Emergency Medicine at Johns Hopkins in Baltimore, as Junaid mentioned. I'm also a practicing emergency physician at Johns Hopkins Hospital, and my subspecialty area of focus is in pre-hospital and disaster medicine. I'm board certified in emergency medical services medicine, and I spend a great deal of my time and my academic and professional interest working with emergency medical services systems in the pre-hospital sense, but also in the interfacility transport sense, building out systems of care, building out programs for EMS clinical performance, and providing direct medical oversight of those programs. This is my 25th year in EMS and my 15th year as a physician. So very pleased and honored to be here during this incredibly challenging time, and really looking forward to sharing my experience and to learning from everyone during today's meeting as well. So I'll turn it over to Asa.
Yeah, hi, good morning, good evening, everybody. My name is Asa Margolis, and it's a real pleasure to be here as well. I started my career in medicine about 2 decades ago as a pre-hospital provider. I currently am also EMS board certified after completing an EMS fellowship at Johns Hopkins, where I also completed my residency and became board certified in emergency medicine. I'm also on faculty at Johns Hopkins, where I'm an assistant professor, and I also function as the program director of the EMS, or Emergency Medical Services Fellowship at Johns Hopkins. I work with Matt Levy in one of our pre-hospital EMS jurisdictions in Howard County, where I function as the associate medical director, and I'm the medical director of the Johns Hopkins Critical Care Transport Program, where we serve Johns Hopkins as well as many of the other affiliated Johns Hopkins hospitals, as well as transport from outlying hospitals throughout the state and other states back to Hopkins itself. So again, it's a real pleasure to be here, and I look forward to chatting with everybody this morning.
Thank you, Matt. Thank you, Asa. I didn't realize you've been practicing for such a long time. You guys look very young.
That's right.
Yeah,
lucky.
In some session we'll talk about what's the reason behind that. But guys, before I start the discussion, the way we would like to run it, and it's for the audience, is we would like it to be more of a discussion and dialogue based on the questions that you guys ask. And Talha, my colleague from Pakistan, is going to put up the email address where you could ask us questions, and feel free to write a one-liner. We'll try and get to as many questions as possible today. So while you're doing that, let me start with a couple of questions from my colleagues. COVID has changed everything from the clinical perspective. We are now practicing a very different in-hospital medicine on these patients, primarily driven by the safety of the healthcare workers, but also really not knowing what works and what doesn't work for this disease, and we are learning every day. So let me ask Matt a very broad question around pre-hospital care and how COVID has changed generally the practices of picking up patients from their home or from the scene to the hospital. What messages are you giving to your, what guidance you're giving to your staff, and how, what is your experience so far? So let's start with this general question.
Well, thank you, Junaid. That's probably the topic of a day-long webinar, but to try to unpack that as quickly as possible, I think what I would say is, as you've alluded to, COVID's changed the entire landscape for this. We have dealt with infectious diseases, emerging infectious diseases, for over the past 2 decades in particular, as part of how we roll with EMS and pre-hospital medicine, whether it was MERS or the other COVID.
You're mute, Matt.
Can you guys hear me now? Is that okay?
Yeah.
Okay, so sorry. All right. I don't know what's going on. So what I was, just to take it from the top, it's a great question. In 2 minutes or less, I'll try to give you the highlights. I think the highlights are that EMS around the world has been facing emerging infectious diseases for some time, be it SARS, MERS, coronavirus, be it H1N1, be it Ebola. What's different here, and what has made this kind of a very challenging situation, is the fact as to how broadly spread this particular illness is. And with that comes not only a change in our response posture, I think, but also a change in how we do business from a protection perspective. What I mean by that is the EMS programs over the past several months have focused very hard and very, very strongly on recognition and screening for persons under investigation. And that screening starts before the ambulance even gets there at the call center, the emergency call center, the dispatch center, if you will, working with our dispatchers and our communicators on asking the right questions, and those questions have evolved. Then educating our EMS clinicians in the field about what the signs and symptoms of this illness are, and how they should take the necessary precautions, and how we have to change our instinctive desire to rush into a scene and maybe slow it down a little bit and try to protect ourselves as much as possible. Tragically, EMS providers have already contracted the COVID-19 illness, and some have unfortunately died from this illness, and that's happened in New Jersey and New York in particular. So the risk is very real, and I think that risk is weighing very heavily on the shoulders of our EMS clinicians. Later on in the webinar, we could talk a little bit about some of the clinical modifications, but we've had to change from the top down how we do business, from alerting and dispatching, providing situational awareness through personal protective equipment, through measures to make sure that we keep our workforce healthy and engaged, and including what do we then do, not if, but when members of the pre-hospital workforce get sick. So I think on one hand, it's as much about the mission, which is providing life-saving emergency medical services to those who need it, as it is about preserving the system so that the mission can be performed. And I'll stop there.
Thank you, Matt. And I think we will, as the next hour progresses, we'll unpack a lot of these concepts and ideas. Now, the other big piece of this is inter-hospital transfers, where the system is trying to designate certain hospitals to receive or be primarily responsible for taking care of COVID patients, while others try to take care of other emergencies. And that creates problems. Of course, patients show up in one hospital, and very soon we realize that this patient needs more, a higher level of care than what can be provided in the peripheral hospitals, and require transfers to larger hospitals. And that, I'm sure, is a huge challenge in many countries. Here in Baltimore, Asa, you run this program, inter-hospital transfers. Could you highlight for us what are the key issues that you're seeing and addressing for COVID in terms of inter-hospital transfers?
Yeah, of course. Great question. So, as you pointed out, we are trying to streamline the care of these patients at our main campus at Johns Hopkins. And of course, these patients present to hospitals throughout our healthcare system, but also to hospitals outside our healthcare system. And, some of the care we're able to offer to these patients can only be done at our specialty referral center. So we are trying to basically pull our resources and bring these patients into us at Hopkins. Now, obviously, this requires a very large effort on multiple individuals' part to make sure that we could coordinate the care of these people and the transport of these people to Hopkins. So the critical care program that I help run, and I'm the medical director of, we basically get calls to go and get these patients after they've been accepted for care at Johns Hopkins. And, you know, not surprisingly, you know, these patients are often quite ill, which is why they're being referred to us, because as you noted, the care that these patients need may not be available at the sending facility. You know, more advanced therapeutics, more advanced procedures such as ECMO that we can offer at Hopkins with basically increased expertise may not be available where they're coming from. So we are sending teams out. We have done all of these transports by ground. To date, we have done about 320 transports, and that makes up both PUI, so people who are being considered to be positive for COVID, and those who are actually confirmed positive for COVID. We have done none of these transports by air thus far because we are trying to ensure the ultimate safety for our crew, and doing it by air brings in some additional considerations that we're able to sort of take care of on the ground side. So all of these patients we've transferred thus far, we brought by ground. Our positive rate of transfer is just about 55% of those that we're taking. And these people range from, you know, more stable to critically ill and requiring ventilator support in advanced ventilator settings to be able to successfully transport these patients back to us at Hopkins. I'm sure as the hour goes on, we'll get into some more of the specific logistics and different types of management we're doing on the transport side.
Right. Let me start with the question that is on top of many people's minds, and that is around safety of your healthcare providers, paramedics, EMTs. And I guess for the traditional EMS, when you get a call from somebody's home and you are trying to triage and get there, take care of the patient, it's a little bit different from going to a hospital where there may be a little more information available. So Matt, in terms of staff, safety of your staff, what procedure and protocols do you have that could help others sort of implement to make sure that staff is not infected?
Well, it's a great question. The discussion continues to evolve as our understanding of spread of this illness, in particular, what is now become more concerned for the asymptomatic spread when someone is indeed infected but is not showing outward signs of symptoms. The question becomes more complicated. Here's been our general approach. Any person, let's start with what we do know, which is someone who has signs and symptoms of COVID-19 or who has risk factors for COVID-19. And let's talk about what those signs and symptoms are that we generally are referring to. So we're referring to a new cough or shortness of breath or fevers or new body aches or new diarrhea. In addition to that, we've added the loss, the sudden loss of smell or taste. And of course, there's still the qualifier for contact with someone who has a lab confirmed diagnosis of COVID-19. So those are some of the highlights of the symptoms and that would trigger us to make someone be a PUI. There were a few other nuanced ones, but those are the big ones. In that context, respiratory protection to include, or what we would say is protection that would include gown, gloves, eye protection, and not just safety glasses, but actual wraparound eye protection to protect from splatter, or a face shield and a mask are what's recommended on those calls to protect our EMS providers. Beyond that, the applying of a surgical mask to the patient is felt to be very, very important as soon as possible to get source control, to minimize the chance of spread. In fact, we've taken the posture locally where we're putting a mask on every patient, regardless of their chief complaint. Because once we do that, we have achieved some degree of source control, and that changes the risk calculus a lot. Now, there's a whole discussion, particularly in the US, about what type of mask should the EMS personnel and should our healthcare providers be wearing. There was some disalignment between WHO and CDC required guidelines on this, whether or not N95 or higher or droplet mask should be worn. Since we have an international audience here, my best advice, I think the most responsible advice I could give you is you should defer to the guidance you're receiving from your official government health authority on that. In our country, we are using N95 when at all possible for our EMS clinicians as they're caring for someone who's COVID positive or suspected COVID, PUI, as Asa said, and when they are within the 6-foot radius of the patient and or going to be in what we would call prolonged contact, which would be, we use the term prolonged contact for any contact greater than 5 minutes. So our position is we like to get N95s on those people, on those EMS providers when at all possible, but we recognize that there's a shortage of these resources. And so in times of shortage, we may have to use surgical mask if at all, if that's what's available. So from a protection perspective, that's been there's a whole PPE or personal protective equipment side of this. That's a quick rundown as to what we're doing. We are also working very strongly now on and being even more aggressive with that posture in terms of having people maybe even wearing masks when they're just doing routine activities because of the concern of preventing spread amongst asymptomatic persons. So I'll pause there.
Great. We are beginning to get a couple of questions. I know one of the questions from Pakistan, from Talha actually is it recommended to delegate a certain number of vehicles on COVID transport? Have you separated your COVID ambulances from non-COVID, or is everything COVID these days?
I'll start with that, and then Asa, you can maybe add from the interfacility transport perspective. It's to our colleague, it looked like Tala, who sent that. It's a fantastic question. That was one of the first things we wrestled with early on was, do we do this? Do we designate certain clean ambulances or not, or certain dirty ambulances? And that was a posture that we adopted, or we thought about it in the wake of Ebola, when we were draping ambulances and doing all this stuff. To be quite honest, we are not doing that. And the rationale is twofold. Number one, we can try to do that, but where the resources will be exceeded too quickly based upon the speed at which this is growing. And number two, what we have found is again, there are cases, our first index case in Howard County where there was a provider who was exposed, the patient didn't meet the PUI criteria. So we didn't even know that they were transporting them. They just had some vague GI symptoms. That's why we've brought in that definition. So what I would say to that statement is it's idealistic. And I think if we had 100% optics and surveillance on each one of these cases, you could do that, but it's just not practical. So what we have to then do is focus on protecting the workforce, preventing and minimizing spread, and also having good hygienic processes in place to rapidly decon these units and to turn them back around. And I'll turn it over to Asa to see what else he may want to say about that.
Yeah, I completely agree with what you were saying. The only stuff I would add, so again, on the interfacility side, our typical crew makeup that we send on these calls is an EMT driver, a critical care paramedic, and a critical care nurse in the back with the patient. For these transports, we add a safety officer. And the purpose of this safety officer is to essentially watch our crew, not participate in any patient care, but to watch our crew don, doff, and ensure all of the appropriate safety precautions and practices are being specifically followed. Because one of the most high-risk times for our EMS clinicians or any healthcare provider taking care of the patient occurs with the doffing process of their personal protective equipment. So this safety officer is specifically designated to ensure when they're putting on or donning their gear, it's done correctly. And when they're doffing their gear, it is also done correctly and minimizing the chance of self-contamination. Furthermore, this is, functions as a person that can watch out for the general surroundings to ensure that people around the area don't accidentally come into where we're providing patient care. Another thing that we're doing on the interfacility side is when we bring in a patient to Hopkins, we are handing all of our patients off to what we consider a clean team. So a team that is in new PPE that then takes over care of the patient and transports that patient from where the ambulance pulls in throughout the hospital, again, with another safety officer to whatever room they're designated. And again, this helps to ensure that we're not tracking any infectious particles in with these crews to the hospital, and make sure that that safety officer is, again, there to watch the donning, doffing process and ensuring there's not any sort of inadvertent contamination of people around the area. So that would be sort of the only other thing I'd add on the interfacility side.
Yeah, and
Junaid, if I could add one other thing, because Asa said something that is so important, and I really want to make sure our audience and those joining us today really emphasize. When we're talking about donning and doffing, that's the act of putting on the PPE and taking off the PPE. And we know that there have been many exposures, looking at lessons learned from other epidemics and other infectious disease situations where the contamination is so high. So one of the first things that we did several weeks ago was we created a series of videos that were just-in-time training that focused on using the equipment that the agency has accessible to it. So there are some great videos out of CDC in Nebraska and UMBC that have standardized training on how to put this equipment on and take it off. But it's also helpful if you are an EMS medical director or a system leader to make training that it's organic to your team and to the equipment that you have, so you can highlight that. And it doesn't have to be fancy. It could be shot with a camera phone and put onto YouTube. Technology is not the barrier there. It just takes a little bit of time to do. I'm sorry, Junaid, didn't want to interrupt you, but that one.
No, this is really important. I was just going to mention that last night when I walked into the nursing break room, the video that was running was exactly what you're describing, how to you don and doffing of the PPEs. And this idea of a safety officer may sound like it is it requires a lot of resources, but if you could, personally, I think is a very, very useful pair of eyes looking at things differently than how the providers might look at. So thanks for sharing those. We have a couple of more questions, and first is from Nico, Dr. Nico Risco. He's part of Hopkins. He's part of the Center of Global Emergency Care. And Nico's question is somewhat challenging, and he's saying that countries that may not have PPEs as recommended by CDC or WHO, does this mean it is too dangerous for them to work? And how do we encourage them to keep working so the system doesn't collapse? I know it's a very difficult question. Sorry to put you on the spot, but any thoughts on that? And if you don't have those gold standard, you talked about this couple of things. What else can you do?
I can start with that, and then Asa, if you want to bring it on from your end, through your lens of the interfacility transport. So Dr. Risco, it's a great question. It's one that we struggle with, and that we're planning for in the U.S. should we deplete our PPE supplies as well. So it's something that we all need to think about. I think about our PPE and our protection efforts as a continuum or a spectrum, with the gold standard on one end, as we mentioned earlier on, and then based upon what we do have left in decreased escalation. I think just the other day, the CDC in the United States put out recommendations on how to use improvised face masks, masks out of cloth, out of cotton, as one example. Now that was meant not so much for the clinical side, but more so for the general population to slow the spread and flatten the curve. I think we have to do the best that we can. We know, at least we believe we know, that this is definitely droplet borne of an illness, and that there are certain procedures that can generate aerosolization or can maybe cause those droplets to hang out in the air longer than we thought. And so I think we have to, knowing that, that's the greatest threat, we have to align ourselves accordingly. So what can we do? There are certain pieces of equipment that can be wiped down and reused. I think at a minimum, if we don't have those masks, a face shield is going to be very important to minimize the viral load that's coming in the direction of the EMS provider. Trying to get something over the patient's face that they can still breathe through, like a cotton mask or a surgical mask is ideal. But it's a very candid and honest question that our colleague Dr. Risco asks, and there's an ethical answer to this as well, right? Because do we knowingly put our personnel in harm's way if we cannot afford the necessary protection for them? I would caution, though, by saying that our personnel go in harm's way every day. More EMS responders in the United States are killed as being struck on the side of the highway than they are by infectious diseases. More EMS providers get killed in the back of a moving ambulance or succumb to patient violence or any of the number of threats pre-COVID that we dealt with. So what we have to do is try to do the best we can and recognize the fact that this is intrinsically dangerous. Most health authorities and most health organizations have prioritized EMS responders at the top of the list, along with healthcare providers, for who should get access to PPE in a triage in terms of prioritization. I would echo the thought that we don't want the health system to collapse. That's not what we want to do, but we should take every reasonable effort to protect ourselves, and that may include and does include the reuse of some PPE. So there is more technology and more innovation coming out about the reuse of PPE as well. And as long as it's not visibly soiled and it's not structurally degraded, we know that those masks, particularly the N95s, can likely be reused several times. And I'll turn it over to Asa for anything he wants to add.
Yeah, great synopsis, Matt. I'll try to keep mine short. So I completely agree with you. I think it's sort of a two-pronged approach. One part is do whatever we can to reduce the potential for viral transmission from the patient. So as you said, source control, so put some sort of covering over the patient's mouth and nose that they can obviously breathe through, and avoid procedures that we know to increase the risk of even aerosolization or transmission of the droplet particles, including nebulized medication, suctioning of the airway, things like non-invasive ventilation if that is something that you have available to you. So identify those things that can increase viral transmission, minimize that, and source control the patient. That's one approach. The second approach, as Matt, you pointed out, is continue to feed back the most current information to our crews, because when they know that they have current information, I think that helps to alleviate some anxiety. So as we see, there's more and more information coming out about let's wear a makeshift face mask, because that can also help. So giving that information back, I think, is extremely helpful, and giving information such as what PPE could be reused and how to effectively clean that PPE, I think, is also helpful and will help alleviate a lot of the anxiety associated with this.
Sorry, just so everybody knows, please feel free to write your questions on the email address that's being shown here on the screen. I will take, the other question, sort of continuing our previous discussion on PPEs, is this sense of anxiety and fear amongst the frontline healthcare providers. And I think, Asa, you did address part of that strategy to take care of that fear, and the fear not only for their own lives, but the lives of their families. What are you doing for keeping the morale up and making sure that people are focused on the job and not becoming too anxious about what's coming through the system?
Sure. So again, I think information and current information is critical. When our providers and clinicians understand that they're getting the most current information from us and that we're being completely transparent with them, I think that helps alleviate a lot of anxiety. Giving regular updates, whether it's via email, via phone call, via webinar, to our providers is extremely helpful. That way they feel like they're empowered. Giving them knowledge makes them feel like they're empowered. When they're lacking knowledge and they're having to search for things themselves, it just generates unnecessary anxiety. So that's one approach. I think the second approach is having a very robust peer support network and network for counseling that is obviously completely anonymous, that our clinicians could utilize day or night should they feel like they need to talk to someone. And having a very clear protocol in place of how to access that, I think, is important as well. It's one thing that it exists, but it's another thing that our clinicians know how to access it readily. So ensuring both a support network for them as well as a support network for their family members is really, really important. And then, you know, it should not go without being said that thanking them and reminding them of how important the work that they are doing is to both, you know, you and all the people out there is really important. It goes a long way when you remember to thank your clinicians and providers that you work with, because, you know, when you're putting in long hours and you're under tremendous amount of stress and there's a lot of unknown, a thank you really goes a long way, and letting people know that they're doing a great job, I think, is really important to keep morale up. Matt, I'll turn it over to you for any other thoughts.
Incredibly well said, Asa. I think that visibility, transparency are really the key. There are a lot of anxieties about this. There are many people who have contracted COVID and have recovered as well. So balancing that messaging is also important. The mental health and wellness of our EMS clinicians and our frontline health providers is on everyone's mind. For all the reasons you've already stated. The one thing I would add, if I can, is the community, the non-medical community has, at least in our portion of the United States, has really stepped up and really, really, I think, embraced and acknowledged the risk that our EMS clinicians and our healthcare system is taking at this time. And we've seen acts of just generosity and acts of true humanity that are really helpful. And I think those little things remind people that their work doesn't go unappreciated, and taking care of each other. I'll share with the world a rather personal story, if I can, for just a second. My own mother is very ill right now, suffering from COVID in the greater New York area. And I was talking, she's not doing well, but I was talking with her nurse on the phone last night about her case. And I don't know why I said it, but at the end of the call, I said, thank you so much for taking care of my mother, because I can't be there right now to take care of her. And I said, are you and your family okay? And do you have what you need? And she paused, and you could hear her voice crackle for a minute. And it was at that moment that we all realized we're all in this together. And so I think that the little things do matter. The big things matter as well. Concretely, I would caution everybody to think about when people are giving us gestures of kindness. Sometimes those very well-intended gestures can actually be problematic. And so for example, people want to donate food and drop off a tray of food that they made. Well, unless those foods are individually wrapped, we increase the risk of spreading disease between each other and things like that. So there are some concrete things as well. But talking, sharing information is, I think, the real important one. So I'll turn it back to you, Junaid.
Thanks, Matt, for sharing. And I didn't realize how close this is to all of us. And thanks for taking out time really for this while you're dealing with your mother's illness. And thanks, Zaid Saab from Aman Foundation in Karachi to ask this question, for asking this question. I'll move on to the next question, and that is about the clinical management of these patients. How do you manage, how has the airway management, for example, changed? How has the CPR, for example, has changed? The overall approach to resuscitation with key points. So maybe Asa, you can respond to this question from Nico about the airway management CPR, and then we can take more questions on that.
Sure. Nico, good morning. Another great question from you. It's great to hear from you, Nico. So yeah, we have definitely modified our approach to both cardiac arrest management as well as advanced airway management in the field. So taking the cardiac arrest question first, we've taken the approach of hands-only CPR. So when we approach a patient who's in cardiac arrest, we apply a non-rebreather at 15 liters a minute for passive oxygenation, and we commence chest compressions. We're doing this because data suggests that by applying and using bag valve mask ventilation, that could further increase the aerosolization and spread and contamination of our healthcare providers, and obviously that's something we want to minimize. There is certainly debate back and forth as to whether or not it's more advantageous in these patients to place a supraglottic airway initially and then deliver ventilation through the supraglottic airway, or to intubate them as quickly as possible. I think there will continue to be debate on this, because if the supraglottic airway that is placed is not placed appropriately, does not seat well, obviously this can increase the chance of even further aerosolization and spread of viral particles. So just simply putting a supraglottic airway in, I don't think necessarily alleviates that issue if it's not placed appropriately. Again, my recommendation would be hands-only CPR. If you have the ability to use an automated CPR device, that is also helpful, because that decreases the people that are directly over the patient. Again, 15 liters via non-rebreather for passive oxygenation, and intubate the patient preferably using a video laryngoscope as early as possible to, again, decrease any aerosolization and spread of the viral particles. From a general airway management perspective, we are definitely de-emphasizing non-invasive positive pressure ventilation such as CPAP or BiPAP, particularly CPAP in the field, because again, evidence suggests that this could increase aerosolization of these viral particles and further lead to contamination of our EMS clinicians. One thing, at least on the critical care interfacility side, we're going to utilize is a high flow nasal cannula. Again, there's certainly no head-to-head comparison of how much aerosolization occurs, but the prevailing thought is that, provided you're able to place a surgical mask over the patient with a high flow nasal cannula on, and your flow rates do not exceed certainly 40 to 60 liters per minute, the chance of aerosolization of viral particles is probably lower than it would be with non-invasive ventilation such as CPAP and BiPAP. So that's one thing we're doing. That's one thing we're doing. Again, patients that are trending to needing an advanced airway, we're doing it early. So we're avoiding the crash airway scenario. We're using RSI, and we're using the most experienced provider to do that airway, so we increase the chance of first pass success. And again, we're using video laryngoscopes. The last part of it, I'll say, is we're, again, trying to de-emphasize any sort of airway type of procedure that could aerosolize, such as nebulizer medication. We're trying to stay away from that in favor of, while it still exists, providing metered dose inhalers for bronchodilators. And then I guess, the only other last thing I'll say is on the critical care side, when we're changing vents, so when we're going from a hospital vent to our transport vent and our transport vent back to the hospital vent, we're being careful to clamp the ET tube. This hopefully helps prevent, again, aerosolization of particles out of the ET tube, but also we found to be successful in preventing the patients from what we call de-recruiting, because they're very, very sensitive to increased levels of PEEP. And if they de-recruit, they'll end up being hypoxemic, and it'll take a little while to help get their oxygen saturations up again. So I'll end there, and I'll pass it to Matt for any other thoughts on it.
That's fantastic, Asa. I think just a couple of things of what you said. That's a great landscape for how we're handling on the interfacility transport side, and also gave some really good pearls about things for clinical management in the EMS field. There is variability amongst local clinical practices and protocols. That's one of the challenges with EMS medicine. And the debate is still on about, is supraglottic airways, are they better than intubation or vice versa. And you highlighted that very nicely. I think the only other thing I would add to that is while there may still be some discussion and some discourse as to what is best and when, one thing is very clear, which is that if a procedure, an airway procedure, can be deferred until the patient can be in a negative pressure environment, like in a hospital or someplace else where that can be done, it should be. So oftentimes in EMS, we've built our EMS systems and our EMS clinicians with tremendous authority and ability to help people. And sometimes things get done ahead of time or done in the field to maximize stabilization. I think that risk calculus has shifted here. And now we really only should be doing airway procedures in the field if we absolutely have to, until such a time where we can provide the environment to do it safely, like Asa alluded to. There are times when patients do need an airway. That's the way this goes. And when that does happen, maximizing PPE and protection for the intubator, minimizing the number of people at the patient's side to minimize secondary contamination and those who could get exposed and don't need to be, is also important. So I'll pause there, but that's the only thing I wanted to add to that.
Thank you, guys. I wanted to move on to a couple of other ideas and thoughts, and we have maybe a couple of other questions that we'll pick up after this discussion. And that's around recommendations for universal masking. So everybody is being encouraged to make home-based masks and try and wear that. That's a community intervention. And I'd like to hear, especially Matt, your thoughts on how do you see that in terms of, is it helpful, not helpful? Should we recommend it to other people as well?
Well, given that large global organizations and public health organizations are recommending it, I don't know it's my place to not recommend it. I think that, sorry, little editorial there. I think that there is value in it, and here's why. I think that we talk a lot about flattening the curve and slowing the rate of disease for these illnesses and slowing the rate of spread. And if there's something that we can do, even if it's not 100% effective, if there's something we can do to slow that rate of spread, I believe we should. That's where the universal masking comes in. And I think there's several tiers or buckets here to talk about. So I very strongly believe that we should universally mask our patients if we have that ability, because as Asa and I mentioned earlier on, there's a source control opportunity there to minimize the spread. The concepts of universal masking of our EMS clinicians and our responders, both while they're out in public and just in general, and I'll focus on the workforce, I think that makes a lot of sense, because we know there are cases where the people develop symptoms and they were around a bunch of people 12, 24, 48 hours before they became symptomatic. And there's some concern that there could have been shedding of virus and spread there. So I think that makes a lot of sense. Where I think the discussion gets a little less clear in my mind is what should be the materials by which we facilitate the universal masking. And I think if we had an endless supply of surgical masks, it would be very simple, but we don't have that. And so we have to think about what could we use. And there are some limited, but there are some studies, there are limited in number, looking at the efficacy of various materials for masking, cotton and so on and so forth. So that's a very long-winded answer to say that I think it's better than nothing at all. I think it shouldn't be an excuse to not do good social distancing and to not do other good hygienic practices. So I think that the role of the masking, there is a role for that. And I think that may actually be one, as we look back and we study this pandemic for years to come and how we responded to it. One of the leadership moments I believe we will realize is that, yeah, getting masks on people sooner was a very key thing to slow the rate of spread. I'll yield to Asa. Asa, I don't know if you have anything else to add on that.
Sure. As you said, flattening this curve is going to take a multifaceted approach. The social distancing, the great hand hygiene, and I agree, the universal masking. I think the rate of the asymptomatic carrier And further, the rate at which the asymptomatic carrier can spread disease is not yet well defined. I think it's definitely contributory. I'm not exactly quite sure how much it contributes, but I would not be surprised to find out that it's not a negligible contribution to the spreading of this virus. So I agree with you. I agree with the national recommendations. At this current point, I think it's part of that multifaceted approach to help flatten the curve and decrease the rate of transmission of this virus.
Right. The issue of keeping the people safe, we've discussed that. Now, what is your process or procedure if one of your employees get ill in the field? What is your threshold for keeping them home when you need all as many people as you need today? And then how long do you quarantine them for?
So that's a great question. Asa, if you want, I'll take it from the EMS pre-hospital side. Then if you can add anything, because I know a lot of what we're doing with our interfacility transports dovetails with hospital policies. On the pre-hospital side, it's an interesting question. And first of all, for those who are with us today who may not be as facile with all these terms, quarantine versus isolation, let's remember that we quarantine those who are not ill. We put people in quarantine to monitor them for the development of symptoms. Once they become ill, then we talk about isolation. It's a slight nuance, but it is an important difference, as Dr. Razak mentioned a moment ago. There are some guidance that has emerged on the CDC website. There's a subheading that focuses on healthcare providers and how you manage them. And I think that has been the basis for at least how we've crafted most of our policy on the pre-hospital side. The EMS clinician, the paramedic, the EMT, the firefighter, the police officer, once they become symptomatic, there's universal agreement, at least for the organizations that I can represent here today, that, and I can't speak for other organizations in other parts of the world who may be suffering from a workforce issue, that people who are acutely ill shouldn't be working. It's just not safe for them. It's not safe for their patients, and it's not safe for the workforce, right? So people who are actively ill with a fever and the cough and the other symptoms of COVID, I would feel very, very comfortable in saying that those people should not be working and should be in a situation where they're isolated so that we can minimize the spread and flatten the curve, as we talked about. Where the discussion gets a little more tricky is the case definition is very broad for COVID, for PUI, and there are lots of illnesses that can and other random things that can present themselves with those symptoms. So what do we do with someone who's either subacutely ill or who has some of the symptoms? And I think that's where this risk calculus becomes a little more difficult, and it's really going to depend upon local resources. At a minimum, someone who's sick shouldn't be working until they've recovered. What we are doing in the organizations that I'm supporting, that I'm the medical director for, is we're saying if they're ill and they're a healthcare provider, first of all, if they're acutely ill, they're a patient, and we need to take care of them too. I think that's the first thing. The second thing is as they're doing through the course of their illness, we want them to not be working so they can recover quickly and get better to get back to work so that we can continue to sustain operations. The notion is who is safe to return to work and for how long, which is, I think, the other half of the question, really focuses on their symptoms. And certainly there's two ways of looking at this using a CDC model. One is a testing, where you have 2 negative tests after they're asymptomatic over 24 hours. The other way is and regardless of whether you do a monitoring phase or a testing phase, the other way of doing this is saying, okay, we want them to be symptom-free for at least 72 hours or fever-free for at least 72 hours with a substantial improvement in their symptoms. That should be no less than 7 days since the onset of symptoms. So we're really giving it a 7-day window. Now, we understand and acknowledge that there's an incubation period of approximately 14 days for this illness. And so we have to balance that in there too. So if those people are returning to the workforce at day 8, because day illness day 5, 6, and 7, they're fever free and they're feeling better, and they return on day 8, they still really need to be masked. And there's another caveat, which is we really want to have them avoid immunocompromised people as well. So that's where this gets really hard, Junaid. And it does go back to your prior statement about universal masking. That an act like universal masking really shifts the entire balance of the equation. And that's why I think Asa and I, as we both said, support doing that. Asa, do you want to add anything from your end?
No, I think that was incredibly well said, to the point. The only other thing that I'd say, again, from the interfacility side, is that if your program is affiliated with a larger institution or university like we are at Hopkins, to make sure that your practices for what you're telling your crews and providers align with what the university or hospital is doing in general. It's important to maintain consistency in policy and protocol, especially for things like this, and you should rely on those experts that work with you within the university to help you sort of navigate these very difficult decisions.
Right. Coming to the from the personnel to the ambulances themselves, and there's a question from Zahir from Pakistan, and he's asking about disinfecting and decon of the ambulances. What's your current procedure? How long does it take? How is it affecting your operations? Asa, if I can request you to respond to that.
Sure, absolutely. It's a great question and a really, really important question. So I think the first thing is, after you're done transporting a patient, to leave the doors open of the transport vehicle, the ambulance, and this is to allow sufficient air exchanges to occur to remove the potentially infectious viral particles. Generally speaking, the time it takes for you to transfer your patient from the ambulance into the hospital, to give report, to finish your paperwork, to doff your gear, should provide sufficient amount of time for those air exchanges to occur. If there are specific questions about that, the CDC actually provides a very useful resource. It's in there, it's Appendix B, it's listed as air, and this actually gives the recommended length of time for the ambulance to sit before staff can enter the vehicle without airborne respiratory protection to allow enough viral particles to be removed. So again, you can actually look at that resource. That resource is very helpful in giving you the specific time that an ambulance should sit before people re-enter it. But again, generally speaking, the amount of time it takes for you to complete your patient transfer and all the associated paperwork and giving the handoff should allow sufficient time. I think it's also important that when we go back to decon the ambulance, it must be decon after every single patient transport. And those that are deconning the ambulance should be wearing PPE. So they should be wearing a gown, they should be wearing eye protection, a mask, gloves, and all of these should be being worn when they're actually cleaning the ambulance. What do you use? So again, CDC and the EPA are very, very useful resources. Using an EPA approved or CDC approved product against this viral pathogen is really what we want to do. And there's a list on the EPA CDC website that people could go to figure out what is approved to do the decon with. Some people will find that using wipes just are not feasible, right? Because the amount of wipes you need to use to get all the surfaces in the ambulance may deplete your entire supply. So sometimes using other cleaning solutions that you could put in a bucket and then mop or wipe down the surfaces with is a little bit better than using specific individual wipes for the cleaning process. I would recommend that all surfaces need to be cleaned. Any surface, of course, that comes in contact with the patient or could be contaminated during transport requires cleaning. So the stretcher, the railings, the control panels, the floor, the walls, any work surfaces, your pen, the clipboard, potentially the computer book, all needs to be cleaned with these approved EPA and CDC products that are appropriate against COVID-19. Again, you should always follow your standard procedures for disposing medical waste. And along with sort of decon in the ambulance, I think it's important that our clinicians remember that we should really be changing into and out of our work clothes when we get to work, right? We shouldn't be going to work in the clothes, working in those same clothes, and then returning home to our family. We should ideally be bringing with us a second set of clothes that we could change into and change out of. And if the opportunity exists to have those clothes laundered then that is something I recommend as well. So again, great question, and I'll end with that.
Great. I know we have last couple of minutes, and I'd like to hear your thoughts about the future. Hopefully, this is going to be a blip in the long journey of humanity and healthcare. And we'll learn a lot and we'll improve a lot. Now, as you look at the future, there are a couple of questions I'd like you to address generally around the training piece. How would this experience change the way we train our nurses, physicians, paramedics, especially now focusing on the pre-hospital care? That's one. And the other question we had from Debbie, and I just wanted to generally address this issue of better standardization across various systems. She asked about Maryland, but I'd like to focus more generally, nationally, internationally, and these differences we have and that impacts the care we provide. Hopefully that will be addressed. So how do you see the future learning from this? How would things change in pre-hospital care? Maybe Matt, you can go first, and then Asa, you can.
Sure. So it's a really, really neat question. From the future, I think I believe we will emerge stronger than this in the end. Once we get through this journey, once we get through this acute phase of what we're dealing with, I think there will be a newfound appreciation for the significance of good infection control and good hygienic practices in the pre-hospital side. Oftentimes those two circles don't directly overlap because of constraints in the pre-hospital world. But I think one of the things that I sincerely believe will change as a result of this will be more standardization of infection control practices and a more healthy application of good infection control, both behaviors and culture, as well as actual practical side of that. So everything we know, as Asa said a minute ago, listen, the reality is we should be decontaminating the ambulance after every patient, not just in the middle of a pandemic. Think about how we could slow the rate of the spread of seasonal flu each year if we use the same infection control practices as we're doing now during a global pandemic of a highly virulent respiratory pathogen. So I think I firmly believe we'll be able to strengthen our system and grow from it. I think there will also likely be a more healthy appreciation for personal protective equipment and its proper use and management. In relation to, I think, the second part of your statement, Junaid, about variations and standardization, variations and nuances between organizations and parts of the world. This is something we struggle with in all of medicine, to be very honest with you. We would like to think that the big pieces should be similar across the world in various types of scenarios, but we know that there's going to be changes and local cultural differences amongst organizations. Part of the reason that we're here doing this today is to share knowledge and share practice, and so people can get ideas to how they're going to adopt that locally. But as brought up earlier on, a big constraint is the resources and having those resources or not having those. What I envision is likely a tiered approach to this moving forward, where it's a scalable model based upon resource availability, and in that resource chain, it's not just physical supplies, it's human supplies, it's human capital, and it's places to take patients to. So those are my thoughts. I'll turn it over to Asa for any final thoughts he may have on that.
Sure, thanks, Matt. Again, well said. I agree. We're going to emerge stronger. We're going to emerge better. We have already seen that things that have come previously have helped to inform better practice currently. The things that we have learned from the Ebola outbreak obviously helped inform things that we are doing now. And I anticipate that things that we are learning now will help inform things that we do in the future. This concept of social distancing is not unique to the coronavirus. This is something we should be practicing always. It's a good infection control procedure. And again, the concept of learning how to appropriately put on or don and take off, doff our gear is, again, not unique to what we're seeing now. This is an important concept when we're doing anything with patient care. So I think what this is doing is bringing to the forefront concepts and procedures that have really always been important and sort of highlighting now why they are so important. So I think we should always remember these lessons that we're learning, as it will definitely help us improve moving forward.
Thank you both. Thank you, Dr. Margolis, Dr. Levy, for your time. I really appreciate you taking our time, and we hope to see you more. This was a great session. I would, in the last 30 seconds, just talk about the next session that's coming up on April 13th, same time. And we have Dr. Taj Hassan, who is the ex-president of the Royal College of Emergency Medicine in the UK. You can see his current affiliations on the screen. And he's going to talk about positivity, pragmatism, and proactivity. It's just such a fascinating time to be positive and to be pragmatic in how we do things. So please join us. It's 9 a.m. Eastern Standard Time, 6 p.m. in Pakistan, where most of our folks are right now. And we'll be sending out more details on that as well. So with that, thank you both again, Asa and Matt, for taking our time. I really appreciate you guys, as well as the team in Pakistan, as well as here at Hopkins.
Thank you.
Thanks so much.